pleasure to have Wissam El Hajj uh, from Lyon University, who will talk about efficiency of anti-inflammatory treatment in Alzheimer's disease.
Okay, so hello, hello, Ala, hello, everyone. Thank you for this introduction. So, yes, today maybe my title is a bit surprising because there's plenty of biological words in the title and only one word of math. But don't worry, the most of the presentation will be math oriented, and the biology will be, I hope, very well introduced, and it will be easy to follow. So, so this work actually is a joint work between several researchers here in Lyon, and today I will be presenting this work. What I will be presenting more specifically, I will start by a biological explanation because, as you can see in the title, I have the word inflammation, I have the word Alzheimer's disease. Even though I know that most people know what is Alzheimer's disease, I believe that it would be better to explain the biology behind it and some hypothesis or some known fact or unknown maybe. It would be easy to understand and to clarify, and then we can proceed with the construction of the model. So here at some point you will see like a break between the biology and the math, and we're gonna start with some equations and so on. So I present the mathematical analysis, and here the analysis will be presented in two parts. First, a simplified model that can be solved analytically, and another part which is for the complete model. I will go back to the complete initial model where I will be working numerically. And last but not least, for sure, I will conclude. So, I will start step by step to present a bit what is usually my field of study. So, usually, I'm interested in the mathematical modeling of inflammation. What is inflammation? Inflammation simply is a physiological process aimed to protect the organism, our body, from various diseases and injuries. For example, if, for example, due to a knife, you had a problem in your finger, or you cut a finger, or you have something, even, or it might lead to the setup of an inflammatory response, which means that is a response our body will always do in order to protect from any injury. If you cut your finger, if you woke up with a bacterial infection, even in cancer, cardiovascular disease, Alzheimer, diabetes, and autoimmune disease, and so on. So as you can see in the figure, inflammation, this, let's say this process happens in pretty much several diseases. And today I will be only presenting the part of Alzheimer's disease. But what I would like to say that in general, my field of interest is to provide a generalized mathematical model to describe the process of inflammation. Even though all of these diseases are different, they are not the same. The process of inflammation is quite similar. I will be presenting it in a bit in the next slides, but just to introduce it. So usually when we have a problem, we have a stimuli, our body will set up, we have the production of inflammatory mediators. Those inflammatory mediators will tell our body there is something wrong happening, there is something bad happening, and then what do we call the immune cells will come to the region of inflammation and try to solve the problem, to remove this injury. Yes, I do have, I guess I have someone is raising his hand.
Yeah, it was just a mistake here.
Okay, don't worry. Okay. Um, and then we have plenty of processes happening when I say migration of immune cells, production, and so on, which I will be presenting in a future slide. What is actually the process of inflammation? Here, as you can see, this is a graph taken from a paper. And here on the y-axis, you have time, and here you have the activity. By activity, I mean the activity of the immune system. As you can, we'll start step by step. We have the trigger, as you can see here at the beginning. Anything. It can be a radiation effect. It can be an internal problem in our body. It can be some genetical problem. It can be, I don't know, you cut your finger. It can be a small button that is going up. It can be anything in our body that due to any stimuli. We will start the stimuli. As you can see, with time, the trigger will increase the inflammation activity. We have the process called the activation, which means all immune cells are activated. You have production of pro-inflammatory mediators, as I have just said before. Those mediators, those cytokines, more specifically, we are called, they will call the immune cells. We say there's a problem, we have to solve it. And here we have two steps. As you can see, we have either the dashed line, in that case, the immune cells are capable, are enough in order to solve the inflammation, which means they will remove this disease, they will remove this stimuli, they will get everything to homeostasis, which means they will everything get back, everything will go normal, and the activity of the immune cell will go down, as you can see with the mouse now. It can go down to come again to the case before the stimuli. The other case is when our body is insufficient, is not capable of removing the stimuli, the immune system is not power enough, and we have the chronification step. The chronification step means we have the setup of a chronic inflammation. What is a chronic inflammation? This is an inflammation that will happen, I will not say every day, but it is chronic in our body, which means it will stay in our body. And here, it might cause the tissue damage. It might cause the development of several diseases. I can say atherosclerosis, Alzheimer, and many other diseases that can be caused where chronic inflammation actually can cause the development of such diseases. And here, indeed, when you have chronic inflammation, it is not normal for our body. It is not a usual state. It can cause several complications like autoimmune disease, genetics, and so many other problems in the future. I will not go now deeper into the biology. This is just as I have told you, this is a general presentation of the process of inflammation. And actually, such work has been an interest for several papers. I was able, actually, and our team were able to finalize. We are able to provide a generalized model, literally a general model with not specific disease. We are able to work on it. We are able to use this model in several diseases like atherosclerosis and to study the role of permeability and heart diseases and even skin disease. So actually, this topic has already led to several publications and work that are officially published in the literature. But today, I will not be presenting this general process of inflammation. I will be more specific to the Alzheimer disease. The process of inflammation is present in the Alzheimer disease. I will explain it just in a bit. But before presenting this disease, I will simply say what is Alzheimer. I pretty much know that many of you know already what's Alzheimer. Alzheimer's disease is part of a neurodegenerative disease. It is a chronic condition that damage and destroy parts of your nervous system over time, especially in the brain. So actually, yes, I guess there's a question as well.
Yeah, I have a question concerning the previous slide.
Yes.
So I mean, before the one, before this, yes.
Yes.
So when it's arrived to, this is the level 0 of the activity, yes?
Yes, here.
Okay, when it's arrived the dash line down back,
yes,
it will be asymptotic parallel and to 0, or it go to 0 then? So what happened there in the
yes.
future?
Yes, I understand. So here it's like I say, it's a schematic representation. It's not exactly a curve. It's just a way to show that we will start from the 0 point where there is no activity of inflammation. It will go up and go down to the 0 level. So it's just a representation. It's not a mathematical curve. But indeed, in terms of math, if you want to say, it will be exponential decay to 0.
Okay, it will touch the 0, yes?
No, it will be yes, it will go back to the previous case where there is no activity. Yes.
Okay.
Yes. Yes, thank you. For the Alzheimer disease, this what happens to our brain. So as I have told you, it causes some damage to the brain, and more specifically, it will go to gradual destruction. So it does not happen once you have the disease. It will directly damage totally your brain. It will be gradual with time. It might take years. It might take sometimes some people die and they don't even know they had Alzheimer disease. Some people it's very fast. Some people it's slow. But usually it is a slow process and it is gradual. So it's happening step by step. And indeed, when you have destruction of the neurons of the part of the brain, you will have we will have death of the neurons, and this will cause a gradual decline in memory, thinking, behavior, social skills, and all of that simple. It will affect the person's ability to function. I cannot say normally, but to function as he used to be before. So, for example, you might start to forget something or to forget to the behavior problems and so on. Actually, now more than 55 million of people have dementia. That is this problem in the brain, the loss of memory worldwide in 2020. And it is expected to be 153 million in the world in the next 25 years, which means the number will triple in less than 20 years, in less than 25 years actually. And those numbers are alarming because we say that these are the cases. There's other people that are known to have Alzheimer's disease. As I have told you, people, some die and do not know that they had Alzheimer's disease. And when I say 153 million, the number should be doubled by 2 or 3 because there are the number of people affected. Because when you have a member of your family affected by a severe Alzheimer's disease case, there's a mobilization with the family. So this disease actually not only affect the person by itself, it's also the people next to him, because they will have to help him. They will have to at some when the disease is very developed, they really have to be next to him and to support. So it's not only a problem of the person by itself, it's not only a medical condition, it is also an economic and social alarming case. This is why we are interested to study this disease.
So just a technical question. Dementia
It's
is
another
another name.
Yes, yes.
Yeah.
Alzheimer is a dementia, which means they affect the ability in the brain.
Okay, thanks.
Yes. From a historical point of view, Alzheimer, I will say it has been like 100 years, about 125 years it has been studied, and it was first of all discovered by a German neurologist called Alois Alzheimer. This is why we have the name of Alzheimer. And the first case goes back to 1901 with a patient called Auguste Deter, and she has 51 years old, and she had some memory problems, language, and some psychological disorders. And this is where she started to have some memory problems, she forgot maybe some words, some language issues. And with that, it was the first, let's say, the patient zero with Alzheimer. Indeed, it's not the first patient, but at least it was the first person diagnosed with Alzheimer's disease. And it started to be widely studied starting this period of time. So, the first question that we usually ask ourselves when we have a disease, what is the reason behind this disease? Promise, I do still have one slide of biology. This is the last slide of biology, promise. So I will start with the math. But just to explain the context, uh, how does it start? What is the main cause? Why does it happen? The reason is still unknown. We don't know why some people have Alzheimer's disease, some people not. Uh, there is indeed some things to say that it might be it might go through the family, it might be to some cases. That honestly, there is still unknown reason. The main reason why you get it, it's still unknown. There is some hypothesis, which is the A beta, amyloid beta, which I'll explain in a bit. So usually here is the cell membrane, that is the neuron cell, and here is the interior of the neuron. You have the APP molecule. Okay, this is a molecule that is usually present, as you can see. And it is usually present in the brain normally. We don't know why. Some people, for any reason, there is an enzyme called the APP enzyme. I don't know the name now. I forgot the name now. It will come and cut this APP molecule. The problem comes here. This APP molecule, it has a certain size. It is either below 40 or above 40. Usually, when it cuts a number below 40, by 40 I mean 40 amino acids. So it is a branch of the molecule. They are amino acids. It is formed by amino acids. So when we have less than 40 amino acids, which is 39 usually amino acids, it's not a problem. It is soluble. It can be removed by the by let's say the process in the brain. But under some reasons, unknown reasons, this molecule when what is cut, it is cut to 42 amino acids. So it's A beta 42. And this is what we call the beta amyloid. The problem with this 42 amino acids, or the A beta, now we will call it A beta, is that it is non-soluble. So it cannot be removed. And a main process that will happen, these beta amyloid, because they cannot solute, they're not solute in the brain, they will simply combine with other beta amyloid of size 42, and they will form plaques. As you can see, this green dot here is a plaque. So they will just combine and they will form plaques. Those plaques are in the brain and they cannot be removed. And you know the limit of the brain is limited. We don't have plenty of space. So when you have a plaque here, a plaque here, a plaque here, this will cause some stress to the neurons because they have less space to do their activity, and this stress will cause a stress on the neurons, and they will lead to their neuron death, and we have the development of the disease. Usually, when we know a person has Alzheimer's disease at 60 years old, he has already plenty of plaques in the brain. So, or he has in the MRI, if you do an MRI, in French it's called ERM, they can do it, and we'll see they have amyloid plaque in the brain. So this is the development of the disease. So beta amyloid, as I have told you, size 42 are toxic, and they will cause the immunity to start. They will cause an inflammatory response to happen, and they will form a plaques. Once they form plaque, they will cause the development of the disease. And as I've told you, this 42 amino acid, this beta amyloid actually is toxic, and they will cause an inflammatory response. And here is the inflammation role. So the inflammation role, as I've told you, it will cause the development of it will help to the setup of this disease, or it might not help as well. And one process is what we call the anti-inflammatory. For example, if I told you there's a problem, and then I put an anti-inflammatory process, what does it mean? The anti-inflammatory, it's like his name. It will tell to the inflammation, calm down, calm down. It's not a problem. We can solve it. And some pills, you all know ibuprofen, some people know aspirin, Advil, and some pills are really known to be anti-inflammatory drugs because they have the action to tell our immune response to calm down, because they will inhibit this inflammation process. They will inhibit this pro-inflammatory wave, I can say, because when we have a problem, there's directly a signal, a pro-inflammatory signal. You have pro-inflammatory mediators that will be produced. The anti-inflammatory will come to decrease this level of pro-inflammatory mediators and to say, calm down, we can able to solve. They will low this inflammatory response. And here, and if you go back to the slide, the anti-inflammatory process starts here, as you can see at the activation process. Once we have this full activation here, if the anti-inflammatory process is powerful enough, it will cause a decay to a resolution phase. But if it is not powerful enough, it cannot limit to resolve this problem, this stimuli. It will go to a chronification case. And so here now I'm located exactly here. And now what we are studying, how this anti-inflammatory pills, how these ibuprofen, I don't know the other name, Ertal, there's Solpadeine, there's plenty of names that are Muserol, plenty of name of medicine that are anti-inflammatory drugs. How will they tell our body that, no, it's not a big problem, do not develop this disease? How does anti-inflammatory will not to cause the development of Alzheimer? Because as I have told you, inflammation plays a role in the development of Alzheimer disease. Here I have added an epidemiological studies, some epidemiological study that say that yes, anti-inflammatory drugs can help. They are beneficial to limit the development of Alzheimer. However, clinical studies say the total opposite. They are non-beneficial. They are not really helpful. And this debate has been a long time. So, and some people have just said that anti-inflammatory drugs are beneficial at the beginning of the disease, but they are non-beneficial at a further state of the disease. Yes, Omar?
Yes, Wasim, thank you. I know your talk is about the inflammation caused by the disease, and
Yeah.
this plaquette will cause inflammation, and then from here you start the modelization of the problem mathematically. But I don't know if it is too short to explain the disease itself, if it is possible, of course.
Yes, I will present it just in a bit. In the next slide, I
I
will
see. Thank you.
in the next just to finalize this idea, and I will go and explain it. Yes, okay. So as I have told you, so again, the main goal of this talk is to present how these anti-inflammatory drugs can be helpful to delay or to see if they can resolve this disease. So the process. And we go back to the question of Omar. So neurons, as you can see, we have here neurons. They produce the A beta monomer. So this process where we have cut the enzymes, I will call this A beta monomer. This is the 42 amino acids. A beta monomer can actually combine two monomer, form an oligomer of size 2, 3. If you add another monomer, it's an oligomer of size 3, another it's an oligomer of size 4. They will combine. Until some time, they will be an oligomer of size n. Here I put it 4 just for illustration, but usually it is bigger. So once we have 4, they cannot be removed. because if two monomers can combine, it can be removed later. So if two, it can get depolymerized. If three, they can be 2-1, or they can add an additional one until reaching a certain size where they cannot be removed anymore. They are stable. And these oligomers are toxic. They are bad. They will set up an immune response. Immune response means means migration of macrophages. Macrophages we have two types. We have the M1 microglia, which are the immune cells of the brain, and M2 microglia, which is also the anti-inflammatory immune cells of the brain. Okay? So M1 will produce pro-inflammatory cytokines, pro-inflammatory mediators, which will cause an effect on the neuron. Once we have pro-inflammatory cytokines, this will activate the neurons. This will tell neurons, increase their activity, there's a problem happening. And here, as you can see, the loop is closed. Here with the M2 microglia, which is the anti-inflammatory macrophages, indeed, they will produce anti-inflammatory cytokines. They will produce some cytokines in our body to state simply, as you can see in the row 7, they will inhibit the production of pro-inflammatory. They will tell our brain, stop the production of pro-inflammatory. It can be solved. Here we have a calm down effect. Here, this is the usual case, the usual body term. In our model, we're gonna add this NSAID, which is the drugs. Here, we're gonna consider it is taken as injection. It can be considered as pills, but they are not considered in this model. So injection, and simply because they are anti-inflammatory drugs, they will inhibit the production of pro-inflammatory cytokines. So the main goal of these drugs is to inhibit the production of pro-inflammatory cytokines. I will start by
I am sorry, Wissam, to stop you here. I just want to understand what happens exactly. Once you have the oligomers, so
yes.
they are toxic, you have a reaction, so you have white cells, and but now you are saying that. So how can you get rid of these oligomers? Like how does the
That's the problem. We cannot get rid of the oligomers because I have told you here, oligomers, they will form plaques and they
Mhm.
cannot be removed. This is the bad part of this disease. That's at some point we cannot, they will form plaques and we cannot remove them anymore. This is
So,
the
so
main problem of this disease.
so the immune reaction is not effective, and
I may not say it's not effective. It is not capable of removing them because they have some physical properties that cannot be removed. This is the problem. But here, actually, I'm really studying the development, the very start of the disease. What happens if there is the beginning of the production? What can I do? This is the main part.
uh-huh. Mhm.
They have a certain death rate. Indeed, they will not stay forever in our brain, but we cannot work on removing them with inflammatory process. This is
Okay.
what I want to say. So here really I'm working on the how it starts the disease. So I'm really explaining how it starts. We have the production of monomer produce oligomer, and this will cause the setup of everything.
Mhm.
So now what we will study how these drugs can cause to stop the development. We're gonna see that sometimes it cannot be stopped, even though we do drugs, even though we do injection, it will not be helpful. We have the development of the disease, it's done. We cannot do anything. But in some
Okay, okay. So this drug will help to stop the disease, and this will make the immune like the white cells become low. Okay, okay,
yes,
I
this
get
is
it.
exactly what the main goal of this presentation.
Okay, thanks.
In terms of math, I know if I will go a bit faster, we have monomers A. A is the monomer, the size 1. As you can see, are produced by neurons. Two monomers will form, as you can see, two monomers will form one proto-oligomer of size 2. And this is the natural death rate. And here, how the two size monomers, a monomer of size 2 will be produced either by the combination of two monomers or there is a and here what will happen if a size it can add another monomer to becomes Fi3, or it can simply die, or it can be taken by the macrophages by the M2 white cells. So white cells can remove oligomers, but it has a slow rate. This is not the main part now. We are back to the question of Ala. They can be helpful, but it's very low. This is why however, we do consider it in the model. And I'm gonna explain a bit later how it happens. So what I can say here, two monomers form an proto-oligomer of size 2. If you add one monomer, a size 3, another a size 4, another a size 5, and as I have told you, they will grow up in size until reaching a fixed size. And when they will cannot neither be removed nor it has a size n, we cannot add anymore and they cannot be removed anymore. So it's fixed, and this is what we call oligomers. So no, we will not consider 17 or however n equations. We're gonna do a mathematical process based on slow and fast variables, and we can add those equations, and we'll only limit ourselves to the following. So A is monomers, U is oligomers, M1 are macrophages, pro-inflammatory, M1 type, M2 anti, C1 and C2 are pro-inflammatory and anti-inflammatory respectively. The model is quite easy. It's an ODE system. I just want to say, how do we model the drug? Here it is in the denominator because it will decrease the production of pro-inflammatory cytokines. So here you can see the production of pro-inflammatory cytokines is done by M1, and we're gonna add the drug here in a way that it will decrease this production. So this is how we were gonna study the effect. And now, how to study this effect? I will not go term by term because I have already explained them before. So in the scheme, so all the pros that you need to know are already explained. So I will not lose some time now to explain every term. I will simply go to the analysis of this model, and then we will discuss several results that are, I hope that they will be interesting. The first thing to do is to study this model, the stationary points, because it's an ODE system. We're gonna set here all the left-hand side equal to 0, and we're going to solve the stationary points or the equilibrium points, it can be known. We either have a case where we have one equilibrium point, E0, that is always stable. We can do it, I guess we can do it analytically. It can be shown that it is always stable. And we have another case where I have existence of 3 points, the 0 point, always stable, and 2 points, EU and ES. EU is unstable, ES is stable whenever it exists. So we have either 1 or 3 equilibrium points, where the one that is common is the 0 point that is always stable. Indeed, you're gonna tell me how did you show that stable? You can use the Jacobian and do the local stability. I guess for the easier, we can do a Lyapunov stability as well if you want to show a global stability. But this is not the main point of this modeling work now. And here I'm gonna say, to show the stability, I will sum some numerical results. What I'm gonna do, I'm gonna fix all parameters are fixed except one parameter, sigma 1. So the sigma 1 here, I will take it and I will change the value of sigma 1. And when I change the value, I will check how many equilibrium points do I have. If the rate death of monomers, then mean monomers will die a lot, they have a high death rate. I only have existence of 1 point. As you can see in black, this is the 0 point and it is stable. Here it is the concentration C1 of the equilibrium point. So the concentration of pro-inflammatory cytokines of the equilibrium point is always 0 if sigma 1 is large enough. We only have 1 point. If the death rate is low, we have the existence of 3 points. E0, as you can see, stable. EU here in red, it is unstable. And another stable point up, which is ES. And here you're gonna tell me, what is this ES? What is this point? What does it mean? Simply, E0 is a non-inflammatory point. 0 described by 0 concentration of C1, C2, M1, M2, 0 concentration of everything. No disease, no inflammation, nothing. This is the safe point. ES is a pro-inflammatory point. It is an inflammatory state because all concentration are positive. This is a stable point. If I reach this point, means inflammation has developed, disease has developed. All points are stable. All concentration are positive, means we have the development of the disease. This point in the middle, it's an intermediate point. For example, if I start here, the process starts here. Which is the closest stable point? Here it is unstable, so I cannot converge to it. The solution will converge up, and it will develop the disease. However, if the initial point is here, I will go down to this stable point because, as you know, we'll be attracted by the stable point. And this unstable point is like the threshold. If I'm above it, I will go up. If I'm below it, I will go down. So here, usually, the process of inflammation starts here, near an unstable point. And I will check. If I'm starting here, I will go up for sure. But if, for a certain reason, I have some drugs that will decrease the concentration of C1, what will happen? It will go down. And now where will I converge? I will converge down. And this is the main idea, how this anti-inflammatory can help me to go from this region in danger to the region below, which is not dangerous. So this is what we're gonna do. And to show it, I'm gonna start by a simplified model. So the full model, trust me, the derivation is very long. I will not gonna go into it. Trust me, really. We're gonna converge to one equation. Under some biological assumptions, we can reach one equation. And this one equation, 11, we have the drugs are still here, and it only depends on C1, pro-inflammatory cytokines. In terms of equilibrium points of this equation, it's the same case, either 1 or 3. So we don't have any problem. We have retrieved cases. Now what I'm gonna do, you have gamma C1, which is a line in the C1 space, and this one is another function. So as you can see, the green is the line, and the blue one is the other function. And here, as you can see, there are the points, the 0 point, the one in the EU, and the ES. So near this equilibrium point here in the middle, I will take the tangent, as you can see, and it will converge here. Now, since I have told you, when we start the inflammation, we are near the unstable point. I'm gonna go to a tangent. I will take the tangent near this equilibrium point and converge my system to this one. Trust me, I will not go now into the simplification. You know, maybe it's a bit blurry, I can say, the process, but trust me, for now we're just gonna assume it's true and we can discuss later how we do the derivation, because I guess it's very technical. But now let's really it what will happen. So this equation will be translated to this one, and this one, as you can see, u1 is the following equation, is very easy to solve in terms of u. I guess anyone that took a course of ODEs can know how to solve this one. Only there's one missing thing. What is d? D is a drug concentration, and it will has an exponential decay. Why it has an exponential decay? Because simply when we do a drug, when you do a vaccine, when you do anything, an injection, directly it is a pharmaceutical assumption, it will directly decay in time. So this is actually why we consider d of t the solution of this. It is an exponential decay. So now we're gonna solve this one. Indeed, this is very easy to solve. Here is the solution at the end with all cases. I will skip it now, but I will show you the solution. Here is the initial condition. Okay, so for any initial condition, I have four cases. Either the value of d is very large. So when d is very large, the solution will go in the black line. It will decay. Here is the C1 concentration. It will decay and go to the minus infinity. Or if d is very large, is very small, it will go down until at some time this drug has no more effect. The solution will grow up infinitely. The solution 2 is the same case. It will go down and then go up infinitely. For another solution case is when d has a certain specific value. It will go and stabilize to a certain point, which is the unstable point. Okay, so if d, the concentration of the drug, is larger than this d star, I'm gonna say, we will diverge to minus infinity. However, if it is smaller, it will go up. And here, the main question will be asked. So assume I will do a dose of 2 picogram per milliliter. The solution will go like the green curve. It will go down. It will reach a point where the drug has no more effect, and then it will go up and will go back to the initial condition. You know, the initial condition is, let's say, 5. I will go down due to the drug effect. The effect has an effect. It will decrease. It will decay, and then it will go up again. And when it reaches again the value of 5, I will count here the return time. So here, this point here is the return time. So how many time does it need for the solution after the drug to come back to the initial condition? This is the return time here. So the return time for the curve 1A in green is around 1.5 days. However, for the curve in blue, it's around 3.5. I'm gonna ask you a question. You're gonna tell me how many pills should I take? Because you know, when you take medicine, you cannot take as much as you want. They will tell you every 6 hours, take another pill. Every 1 day, take another pill. Here, we're gonna say, when you go back to the return time, take another injection. So, the blue curve, it has a dose of 2. So I decide to take 2 picogram per milliliter. I will take this dose here, this initial dose of drugs. I will go down and then I will reach the initial condition again around 3 days, more, 3.5 days. Whereas If I take the same dose but divide by 2, I will take dose 1, then dose 1. The first dose, we will go back around 1.2 days. And then, as I have told you, we have to take another dose. We will take another dose of 1. We will do it again, and it will be here. So the final return time is less than 3 days. So here I'm going to ask you, what's better? It's better to take one dose of 2 and to have the return time 3.5 days, or it's better to divide it into 2 doses and have a return time of 2.4? What's better in terms of, again, I want to increase this return time. I want to delay the development as much as I want. So which one is better, to take one single dose that is large or to divide into 2 subdoses? I don't know if someone is following.
Well, one if it is.
Yes, indeed. So it's better to take one single dose because it's larger. It will increase time as much as possible. So this is actually the case where we are at the unstable point. We are at the beginning of the disease. So as Ala just said, a single dose is more efficient than consecutive. If you can take one single dose, take it as large as you can because this will be very beneficial. This will increase the return time. This will take it as much as we can. But if this, not boss, thanks, if this allowed dose is very large, it can go directly to 0 as you can see in the form. But if you cannot take a very, very large dose, take the largest possible to increase as much as you can the return time. Yes, Omar.
So, and then the next question is, what is the largest possible? So,
Yes, the largest possible depends on the case. So actually depends on each person by itself. For example, if you take ibuprofen, if not mistaken, you are allowed up to 6 pills per day, for example. So it depends on the medicine and it depends on the person. But if you can take the maximal allowed dose, I want to say, if the maximal is very large and it will decay directly, take it. If it is not it's not enough, take the largest possible, because do not divide it into 2, because if you divide it, you will have a smaller return time. This is the main conclusion of this case. So the optimal dose is the maximal allowed dose.
Excuse me.
Yes.
For example, if you take the large dose, can you go back to, yeah, here. If you take the blue one, is it
Yes.
possible, for example, after 2 days, you take another one?
Yes.
So you,
Yes, but it depends when you will be. So here, for example, in 3.5 days here. So your question is very interesting. I will be replying to it in a further slide. Uh, so let me tell you, let's consider only one treatment. So I'm only allowed to take one treatment for now. One treatment, either I take it one dose or I divide it into 2. So your question is, if I can do after 2 days another treatment, what will happen? This is your question, right?
no, I mean you take another treatment before going back to zero. For example, if you take the blue one, it needs 3.5 days to go back to zero. But after 2 days, it's near to, yeah, it's near to the
Yes.
purple curve, and you take another one, a
Yes.
smaller one maybe.
he want to say before to arrive to the level 5, which
Yes.
is you start. Yeah.
Yeah, I understood the question. I will answer it in a later stage. I don't want to reply now because I will spoil the results. Sorry.
Okay.
You have
Okay,
to
thank
be
you.
patient for me, like 10 slides, not more, promise, and you will see the answer.
All right.
I
Thanks.
don't want to spoil the answer. It's in 10 slides, promise.
Thanks.
Okay. So now this work has been done for the simplified model. We are able to solve analytically. All of that is proven analytically. And then you're going to ask me, what about the complete model? You were so happy about your complete model of 7 equations. You did a large presentation for it. Why did we do it? And now this is the answer. I'm going to repeat the same process for the previous model, for the complete model. So the same thing I've done. I cannot do it analytically anymore because it is a very long process. It has several equations, but we will do it numerically. And if you remember this scheme, I will consider 2 initial conditions. The first initial condition is this one. Initial condition 1, it is a point at the beginning of the disease. So the disease had just started. If I don't do anything, nothing at all, no drugs, simply, if my solution is here, I will go to the stable point here and my disease will develop. But if I do some drugs, it is very strong enough, I can go below this line, and now my solution, why I don't have the development of the disease, no inflammatory response. It's perfect. I will take the case 2, a point that is here, which has a higher level. Why do we take a higher level? Simply, mathematically, when you have higher level of inflammatory cytokines, mean that you are at an advanced level of the process. So the process is more advanced, the disease has started to develop because all concentration are higher. So here what I'm gonna compare. Here, the case below is the beginning of the disease. And here it is an pretty much advanced stage of the disease. The main comparison will be, if I do a drug treatment, will it be more beneficial for the beginning or for the advanced stage? And the other question, what will be the optimal dose? Is it better to take the largest dose that is possible as in the previous case or not? And now we're gonna start. So now literally it's I know usually when I present this presentation it's very funny because we start by biology, we do ordinary differential equation, we do math, and now we start by an optimization problem. So again, what is the optimal dose to have in order to stop or delay the development of the disease? The first case is with the beginning of the disease. Very happy we get a same case as before. So there is one single dose value. So here is the initial condition. As you can see here in red, I will do at the beginning, I will do a dose. If the dose is 0, I didn't do anything. Simply the solution will grow until stabilizing at this point here and stabilize at the equilibrium point ES. Point ES, inflammatory point, the disease has developed, we cannot do anything, the disease has started. However, if I do a very large value, for example, a dose of 2, as you can see, a dose of 2, the solution, the inhibition is very strong. It will decay and reach the point 0. 0 point, no inflammation, no disease. Perfect. For a certain value, which is specific, as you can see in the blue, this is the threshold. If I use this value, I will converge to this point here, EU. Okay, but this is very specific. So if the concentration is less, between 0 and 1.6, as you can see in yellow or in magenta, the solution will decay because of the drug. It will decay, and then the drug will have no more effect. It will grow up again until, again, here you can see, it will touch the initial condition, and this is the return time. This is the time I have just explained before. But as you can see, it will not be beneficial. It will go up again. Similarly, for the purple, it will go down. It will reach a return time here of around 75 days, and it will go up again. So the main question here, what is better? So your question, Bilal, here is, here I'm calling one treatment. So I'm doing only one drug. Okay, I'm only one treatment. I'm not allowed to do 2 treatments for now. So I will go to your question later. I didn't forget, I promise. So what I will measure, when I change the dose, if I can do a dose of 0, a dose of 1, a 1.2, 1.3, 1.1.5 until 1.6, what is the return time? Because I want to maximize this time. If I can take a dose of 2, which is the green, take the 2, it's fine, you will solve the problem. But if I cannot take a dose of 2, what is better, to take one dose of 1.5 or 3 times 0.5? One dose of 1 or 4 times 0.25? This is the question. Again, I want to develop as much as I can. As you can see, sometimes with drugs, we can postpone the development of disease for years, for at least 1 or 2 years. Imagine, instead of developing now, we will develop in 2 years. It's beneficial, I can say, even though it cannot stop it, but it can be beneficial. This curve actually is the return time dependence on D0. So if I take a dose of around 0.25 or 0.3, my return time is barely 1 day. But if I take a dose, for example, of 1.6, my return time is around 100 days. And 100 days is like half a year, third of a year. If I take the dose of 1.64, for example, here it will be, my return time is around 225 days. So I delay the return time for around half a year or even more than half a year. So my question here, we're gonna go to the same question. The maximal allowed dose is 1.6. So maximum, you can take a 1.6. What's better, to take 1 time 1.6 or 2 times 0.8? If I take 1 time a dose of 1.6, my return time will be here, T maximal. It's around 100 days. If I take the first dose of 0.8, my return time is here, it's around, let's say, 22 days. And then, after 22 days, I will take the other pill, the other drug. What will happen? My maximum return time will be here. It will be less than 22 times 2. It will be 44 days. So what's better? To take twice 0.8 and have a return time of 44 days, or take one single time 1.6 and to have a return time of 100 days? What's better, to delay the development of 100 days or of 44 days?
Of course, only one to have 100.
Yes, so it's better again to have one single dose. So here I have retrieved the same case as before. Take the maximal dose, it's better. Whatever, the maximal dose is always better because we are at the beginning of the disease. Why do we have that? We have some mathematical properties. As you can see here, this black curve verifies the following condition that is below. This is the convexity. Another way to write the convexity, this curve is convex, as you can see. This is why the optimal dose is the maximal dose. So here, a single dose can change everything. The optimal dose is the maximal dose. And now we're gonna start with the other case. If initial condition 2, I will go back to the slide. I'm here at an advanced level of the inflammatory response. Do we have the same thing? Do the maximal dose is the better? The answer is no, because simply the answer is no. Numerically, we retrieve the same case as here. For a single dose, we'll go to EU. For 0, we'll go up. We have the return time, and we're gonna proceed exactly the same. And here comes the shape of the solution. Sorry. Yes, here. Here comes the shape of the solution. I will remove this one to put it here now. Okay, here. And simply you're gonna notice that the curve, the dependence of the return time to D0 is not anymore convex. Because as you can see here, there's a part that is concave. And we have lost the convexity property, right? Here it's not anymore convex. And here, in terms of optimal study of the regimes, there's something not bad, but there's something not the same happening. Just to prove a point, I will do the same process. If I take, I'm allowed to have a dose D1. D1 is the first point, as you can see, I will take D1 here, the first point where the function starts to be convex. Because here, as you can see, f prime is bigger than f over d. This point, it is equal, and for all the remaining curve, f prime is less than f over d, which means after this point, the function is convex, below it is concave, so here it is the inflection point, let might say. I will consider D1. What's better, to take 4 times this D1 or take, so D1 is 0.45, let's say. What's better, to have 4 times a dose of 0.45 or 1 time a dose of 2? What's better? If I take 1 dose of 2, simply, directly, I will take the dose of 2 directly. My return time is around 45 days. However, if I take one single dose, which is 0.45, so I divide the 2 into 0.45, 0.45, 0.45, 0.45. My return time for the single dose is around, I can say it's 15 days, a bit more, 18 days. If I take 4 times this D1, my return time will be 4 times 18. It will be, I'm lost. Less than 80 days. I don't know, less than 80 days, 72 days, let's say. So what's better now? It's better to take one single dose, a large dose, and have a return time of 40, or to have 4 times the small dose and have a return time of 80. What would be better now?
Of course, 4 dose.
Yes, for now, and it's changed. Before, the maximal dose is better. Now it's not the maximal dose anymore. It is to divide the dose. And what is the property of this dose? I have chosen this D1 very specifically. I took you with me with the process, but I chose it very specifically. This D1 is the first value where this function is convex, or where this function changes its concavity from concave to convex. This is why this point is very specific. So this is the optimal dose. This value here is the optimal dose. It's not anymore the maximal as the previous case. Here I will explain a bit more about how to choose the optimal dose. I guess you already got how to choose the optimal dose. The optimal dose is the best dose to choose to have the maximal return time. Indeed. So we aim to maximize the return time for the solution. In the early stage, this is the maximal dose. In the next stage, we have just said it is not anymore the maximal. And now I will add, there's no optimization flow with no constraints. I will add 2 limitations because it's not a happy world. We have some limitations. First limitation, a single dose cannot exceed a maximum value. If I take 1 dose, the maximum value is dm. You cannot take a dose very large. It has a dm value. I will give you, I guess dm is 2. I will do an example. And and I'm going back to a question of Bilal now. If we have a treatment, there's a study that says over 100 days, you cannot exceed a total value of doses. If you have 100 days, you cannot exceed more than four doses. I am allowed a maximal in 100 days, 4 doses, max. This is the two conditions. So I have over 100 days, 4 doses maximum, concentration of 4 maximum, and each dose cannot exceed a value of 2. So each dose maximum of 2. Over 100 days, I can only take maximum a total of 4. So here I'm gonna take two cases. Since I will take the value of 2, how many times can I take the maximal value if I want to do 4? The first time I do 2, the second time I do 2. This is the black curve. I do the first dose of 2, I will go back to return time around 40 days. I will take the second one, I have an 80 days. The total return time in yellow. However, if I take this D1 is around 0.45. So 0.45 is allowed. It is less than 2. I can do it, not a problem. But over 100 days, how many times can I do it? I can do 0.45 times 8 to reach to less below than 4. So over 100 days, I can take 8 doses. Well, this is what we're gonna do. The first dose, it's fine, I'm here. The second, the third, no, until the 8th. The 8 is here, we will go down, and the return time will be 120. So over 100 days, we do a single treatment. Again, we have this single treatment over 100 days. Again, it's better to divide the doses into 8 and not to take only 2 because the return time is bigger. This is the main conclusion here. So, this is the main conclusion here. I wanted to say that in this case, in the advanced case, it's not the optimal dose, is not anymore the maximal. It has to be chosen specifically. And now, Bilal, I promised, I'm to your question now. What will happen? We're gonna fix this condition. I'm gonna fix that. I will use this optimal value. I will use this D1 now. Okay, I will use it. And I will see. If the maximal dose over 100 days is very large, instead of taking 4 doses a maximal. So here again, the yellow, it is the 4 doses. Okay, instead of taking 4, I'm allowed to take 14 doses. I can take as much as you want. Remember, you told me if I can take before returning here. Can I take a dose before? Now I can tell you, yes, I'm allowed because the doctor told me you're allowed to take, like the blue curve, 8 doses. So I'm allowed in 100 days to take 8 doses. So instead of taking only 4, why not taking the 8? What will happen? So instead of waiting every 25 days to take the second dose, I will take it every 12 days. What will happen? I will take the first dose. After 12 days, I can take the second because I'm allowed to take 8 times. And then I will take another. Every 12 days, I will do the process. And as you can see, we will delay the development of the return. If I take only 4, if I do over 100 days, I'm allowed a total dose of 4, my return time will be less than 120 days. However, I'm allowed 8 doses in 100 days, my return time will be around 140. It's better. If you can take more doses, take. It's better. It's beneficial. Simply here, you can see it. But if I can take, and I guess now this is a question of Bilal when he told me if I can take more and go below this line, what will happen? This is the case. If I can take 14 doses, so I can take the same dose 14 times. Imagine 100 days over 14. It's like every 7 days took an injection. The first day, the second day I will take the other, and then I will take the other, and after 7 days, I will wait, and then every 7 days I take an injection. After some point, I will go below this unstable point, and when I am below this unstable point, what will happen? I will converge to the 0 point. So now, is it better to increase the frequency of the treatment if allowed? I will ask Bilal because I guess this is the question
Yeah,
of
of course, yeah.
yes. This is the question of Bilal. So Bilal, yes, if I can increase the frequency, I can take the second dose before, it's better because if you can do it, we have two cases. Either the frequency is very high and we can go converge to the 0 equilibrium point and we have no more disease, or it will simply delay the development. Instead of 100 days, I will have 140 days. In any way, it is beneficial, I can say. It will either delay the development or remove it totally. So this is
But
the
it is
main.
necessary to take the optimal value. Yeah.
Yes. Here we are considering the optimal value. Indeed, yes. So here actually I have repeated the same problem with another optimal value. The conclusions are the same. The conclusion by mean I will get the same conclusion. It's better to take more frequent, but to get the optimal time, the maximal time, it's better to use the optimal drug. But if you take something bigger, you will get the same conclusion that it's better to be more frequent. But to have the maximal time, it's better to have the optimal dose. Yes. And by this question, I will go to the conclusion of this part that the optimal dose is chosen specifically. It is the first point that verifies this equality. And a single dose can delay the development. Increasing the frequency is very helpful in this case because it can either stop the development or it can delay the development. And in both cases, we are happy. And now the last part. I will see. If you remember, I've started. Promise, I still have 5 minutes because you told me 1 hour. So promise, I'm on time.
Yes, yes.
So I will do the comparison between two cases, and yeah, I will do the same treatment. I have two initial conditions: the at a low stage of inflammation, at the beginning of the disease, or at an advanced stage. I will do the same process. I will do 5 times the same doses. Nothing but 5 times the same doses. What will happen? The 5 times, as you can see, if I do at an advanced stage, I do 5 times the same. Every 20 days, I do a dose. First day, second day, third, fifth dose. And it will go down and it will go up to a return time of 120, less than 120 days. So at an advanced stage, this treatment gave me a delay of 120 days. So my disease will be delayed of 120 days, which is a third of a year. However, at the beginning of the disease, I will do the same process, the same disease, the same treatment. I will do it, and what will happen? It will converge to the 0 point. So the main conclusion I want to say here, a treatment of a disease of NSAIDs, of this anti-inflammatory drug, is more beneficial at the beginning of the disease rather than at an advanced stage. At an advanced stage, it can delay its development, indeed, but 120 days over a disease of 40 years is pretty much nothing in terms of days, because 40 years of the disease, I'm just telling you that I'm delaying it 120 days, on a third of a year. It's fine, it's delayed, okay, it's beneficial, but is it fair enough, or is it enough to say that I really delayed the development if the disease takes 40 years to develop? This is a question mark. And the simple conclusion that at the beginning of the disease, when you know that you are at the beginning of the disease, a single treatment, not a single dose, a single treatment can stop the development of the disease. Here I'm gonna skip this one because I guess it's not anymore. I will be repeating the same things. So this is the main conclusion I want to say for this slide. So efficiency, is it efficient or not? A single administration of drugs can inverse the dynamics at an early stage. At an early stage, if I do a treatment that is very beneficial, that is very well studied, I can say, I can reverse the dynamics, which means I can stop the development of the disease. However, after a single dose, the disease needs more time to develop for smaller initial conditions. For smaller initial condition at very beginning of the disease, the disease will need more time to develop. This is logically because we have just showed that it can either delay it as much as possible or simply to cancel it. But at an advanced stage of the disease, it is not efficient. It is not efficient in terms that it cannot stop the development, but it can delay it as much as possible. So, what did I present today? I proposed a system of ODE to study the effect of drugs on the development of Alzheimer. I start with a simplified the system. I distinguish two different cases of the disease for the complete model: an advanced stage and an early stage. I have presented, and actually we have done it together with Bilal and Omar and Ala. You were we are participating actively with the project. So together we are able to choose what is the optimal dose to delay or to stop the development of Alzheimer. We have shown that at the beginning of the disease, a treatment can stop the development. At an advanced stage, it can delay. The treatment is more efficient at a beginning of the disease at an early stage rather than at an advanced inflammatory state. And the results coincide with with several actually epidemiological studies. As I have told you at the beginning, epidemiological studies state that at early stage of the disease, the NSAID are beneficial, and in this model, actually, I was able to show this, and the clinical studies contradict by saying that at an advanced stage, it is not helpful. Indeed, I have shown that it cannot solve the disease at an advanced stage. A treatment cannot solve the disease, but it can delay its development. So in all cases, the results coincide with epidemiological studies. And the main question that you will, I guess I will get it as question, but I will answer it before that you ask, what early means? What does it mean, an early stage of the disease? Because when I have told you, when a person knows that has Alzheimer's disease, plaques are already formed. When you do MRI, plaques are already in the brain. So when a person notices that he has Alzheimer, he is already in advanced stage. So a drug, anti-inflammatory, will not be beneficial. This is why I have read several studies. You can read actually on Google if you only state NSAID for Alzheimer. They will tell you that the early stage is at around 40 years, that the people that at 40 years, maybe 35 at the age of the disease will start. But we don't know. After some time, when the disease is is started to develop, we will start to have symptoms. And this is where we're gonna go to see the doctors or the people that are responsible of the health, and they will tell us, you have Alzheimer, but it's already an advanced stage. So this is why we cannot always take drugs as much as we can. You cannot take ibuprofen with you every day. It's not safe because you are not allowed. You should have prescription of your doctors. But what can I tell you as a take-home message from this presentation? I can tell you, instead of having pills or injections, simply eat some food that are anti-inflammatory. They have anti-inflammatory effects. This will boost your immunity, and this will give a kind of an anti-inflammatory treatment. So I suggest to eat salmon, to have olive oil, to have nuts, to have avocado, to have I don't know what's the name of this. Basilic. So it's better to have such type of food that have anti-inflammatory properties in this type of food, and this will be helpful to not to take this model with you everywhere you go. So just this is the take-home message of my presentation, and thank you for your attention.